let me just open the second webinar for Aptos. My name is Ming He. I'm the current president for Asia Pacific Tele-Ophthalmology Society. Welcome to our second webinar. Today, actually, we have a very special program. We have two speakers from Arvin Eye Hospital. As we know, Arvin Eye Hospital is the largest eye hospital or like eye care service system in the world. They are serving more than one, as far as I know, the hospital, the Arvin Hospital in Mandurah, they're serving more than 400,000 patients and 50,000 surgery in a year. So as all we know now is the COVID-19 is affecting India, and I'm sure it was creating a lot of challenge for people to practice ophthalmology in particular. So today we're going to have two speakers, Dr. Venkatesh, and Dr. Toshi, we will always call him Toshi, to present and share their experience in Arvin in terms of how they run the ophthalmology service during the COVID-19 challenge. So may I invite Dr. Venkatesh to share in particular system and behavior innovation in eye care during the COVID-19 pandemic. Thank you, Dr. Venkatesh.
Yes, yes, Professor. Thank you, and thank you for the kind introduction and the opportunity. If you can close your screen, I can start sharing. Yeah.
Yes.
So again, greetings from Pondicherry, where I am in south of India. It is on the east coast, and we all know we are all going through this unusual situation now, where this pandemic has kind of brought the world to a standstill, and it's been a difficult for every healthcare, including eye care. I'm going to share some of our experiences since we had this lockdown and unlock which is happening in the country and across the globe, starting from the last week of March. It's almost more than 100 days now, but still it's going on. So Professor briefly said about the volume of Arvin. So on any given day, this system sees close to 13,000 outpatients, and we do close to 1,500 surgeries with several of our tertiary care centers, secondary care centers. We have outpatient clinics and also primary eye care centers, which have been a backbone for us. And we do a lot of outreach eye camps through which we see patients, and we bring in patients from the outreach campsite for surgery to the base hospital. A lot of teaching program happens for residents and also people related to ophthalmology in the form of technicians and administrators. So what happened as we had to go on with the pandemic. So the problem is the virus kind of wiped out everything. We had our tertiary care centers and some of the secondary care centers running and doing emergency work. And during the lockdown for almost 60 to 70 days, we were seeing 1,500 patients. That is almost 1/10 of our normal workload. We were doing 75 surgeries, which were actually 1/20th of our normal workload. And all the outreach activities have been suspended even till date. And most of the classes we had to shift to online platform for both for our residents and also for our technicians. As an unlock happened in the first week of June, we are still in a kind of partial unlock. We are seeing close to 3,500 patients every day across our system. You see most of our tertiary care centers, secondary care centers, and some vision centers are open now. Eye camps are still suspended, and we are still continuing online classes for residents and technicians. So I'm just going to briefly take you through what we have done in the last 3 months to make sure that we give the same quality care to the patients who are attending us, because most of them are coming now are kind of high risk or emergency cases. When the lockdown happened, it was a surprise for everybody. There was totally nothing to even buy. Even all the supply chain was down. So there was restricted transport. There was a break in the supply chain. And we had to give the utmost safety for both our patients and also for our staff. Here, I think the staff became a big priority because everybody was alarmed by this problem and they were also concerned about their safety. At the same time, we didn't want to compromise the patient care. So we all know the different transmissions. I'm not going to go into this, but every day there are conflicting reports and more evidence, and WHO is changing the guidelines, and we all know it can go through touch, it can go through aerosols and micro droplets like this. So even when we are talking loudly, or when we have a kind of sneeze or cough, the droplets can carry the virus up to 6 to 8 feet. So there was always a worry in ophthalmology because the doctors are too close to the patient. So the doctor can get infected from the patient, or the patient can be infected from the primary care physician. So either side we need to protect. And as Winston Churchill said, never let a good crisis go waste. Now we saw this crisis as an opportunity to make a lot of changes or incrementally do some innovations within our system. So basically I'm going to share with you some of the system innovations, and also some of the, because here I think COVID has changed our behavior, especially in social distancing, hygiene, and also kind of protecting ourselves with personal protective equipment. It may be a mask or a shield, wherever the need is. So a lot of behavioral change has to happen, but we need to make that into a system. So we have tried to develop a lot of innovations towards it. Let's see some of the system innovations we have done. The first is to change the layout. Now we have 3 blocks like this in most of the Aravind hospitals for the charitable patients, the camp patients, and also the outpatient entrance for the paying patients. So we blocked all the entrance and we had only one entry. And we made sure we don't have, most of our buildings are environmental friendly buildings. So we had all the air conditions off, and we had removed the curtains and brought a lot of ventilation into the building. And we had a control on the building by the entry and other checkpoints which we have. So this is just to show you what happened. This is what normally everybody is doing. So we are also trying to triage and also make sure any symptomatic carriers cannot get into the system. There is a way of kind of segregating and sending them to facilities where they can be treated. So the temperature is monitored, and also a consent form regarding their COVID symptoms with them or with their relatives. Everything is meticulously done outside before they can even enter into the hospital. So the other important thing which we really revisited and we did was history over phone. So we all know that most of the time we spend a lot of time in taking complaints and history of diabetes, hypertension, cardiac issues, history of eye problems and family and all that. So which used to take a considerable time for the doctors when they are sitting in the front of slit lamp or in front of you. So we came up with an idea of why don't we call these patients when they are sitting here. So we maintain a social distance, at the same time we get all the history. So we engaged some of our young residents because the volume was less, there was no outreach activity. Now we could engage them in a better way so that they could enter the history through the electronic medical record, the complaints and history, even before they can come into the doctor's cubicle. So this was one important change. We made a significant reduction of chair time. And also we looked at the clinics and the facilities. So we had to bring a kind of a unit which is now outside in the lobby. So this is basically created so that there is a lot of ample ventilation here, so that this cross ventilation can really help us to make sure all these aerosols are kind of removed quickly from the building. And we had to bring the vision, the optometrist, everybody outside, so that they kind of work in a very safe atmosphere. So even if you see the doctors are working in a very safe place where there's good cross ventilation. And also we have given a scribe to each of the doctors. So the junior residents became scribes so that they don't have to go and enter into the system. So the contamination of the mouse, the keyboard is also taken care. And this system is still going on. So this again expedites and also reduces the touch. So the doctor here is examining, and then the other person helps you in kind of entering all the information. This is just to show a layout in most of our hospitals. This is what has happened now. All the lobby has been converted into areas where patients are triaged and all the new patients are taken care. So only people who need some specialized opinion in glaucoma retina clinic enter into the basic clinics for their examination. So basically the idea is again to reduce the time in the hospital and to make sure that they leave the hospital as quick as possible. So this is a kind of layout which you are seeing at present. This is the video taken at Aravind Eye Hospital in Pondicherry. So all these have been brought outside from the vision, and the physical distancing is maintained in the registration area so meticulously. We all know the slit lamp is the one which we can never avoid in ophthalmic examination. And when we had COVID coming up, each and every company started giving us slit lamp breath shields, and most of them were not adequate in size. So we wanted to study which is an adequate sized slit lamp shield, which will be safe for our patients and also for our staff. So we did a lot of experiments in-house like this with simulating a sneeze and a cough, and we found that most of the breath shields were very small, and the micro droplets can cross, and either they can fall on the doctor or the patients. So see, we came up with a different dimension for the slit lamp shield, and we also did this in our local lathe which we have within the hospital, and which is again friendly for the doctor, so that it has got a small cut on either side, so that they can also do some of the tests for the patient and also do some procedures like lid eversion and applanation and things like that comfortably. And we again retested with the new size, and then we found that absolutely there were no droplets. So we came up with this plan, and we gave this plan to Aurolab, and Aurolab is now manufacturing the safe breath shields for us, and now we have fixed this in all the slit lamps. So going back to eye examination, again we know that eye examination needs a lot of contact. You are using gloves and doing it, but many of the time you are not even comfortable with the gloves. And also in high volume systems, you can't be changing a glove for every patient in the outpatient. In surgery, it is possible. So what we did was we again had a hackathon, and our team came up with brilliant ideas. This is one of the idea called Eye Opener, which we have also submitted for a publication. So this is basically two buds which goes into a 3D printed holder, and then which can be used comfortably to open the eyelid. And also now they are doing some incremental changes to it so that you can avert the lid and also to see that. So to make sure the registration team is safe, the counselors are safe, we have, this is how the old system used to be. Now we have a very safe cubicle with a glass which can be cleaned in between, so that their droplets and other contact is not with the patient. Same way our counselors have to be protected. Now they are with the patients explaining about the surgery and treatment. So we have come up with a simple design of tabletop COVID safe shields, which can be placed in a 4-feet table comfortably, so that there is a nice barrier for both the patient and the attender with the counselors. So these are some of the simple things which we kept doing over the period of time in the last 2-3 months. And we all know the personal protective equipments are very expensive. At the same time, there is a high demand for it. And CDC also recommends that you have to safely kind of decontaminate and reuse some of these things. So our team came up with a brilliant idea of using a freezer box. This was a condom freezer box, and they have fitted UV light, and they have also added mirrors to the side and the bottom of the freezer box. And we have now a systematic way of decontaminating the N95 mask and the respirators used by the medical team and the paramedical team. So at the end of the day, they put it in a paper cover, and then we have these CSST staff who are already working in the operating room. So we have put the freezer box there, and they hang this in the UV freezer box inside like this, and then they close it and leave it for a 15 to 20 minute cycle for the decontamination to happen. And once the decontamination is over, it is put in a Ziploc pouch with the doctor's name for them to use the following day. So this is one way we are able to reuse some of this highly valuable personal protective equipments. So just going back to, I'll just quickly go back to the next part of it. So the next part, I just briefly touch on some of the behavioral innovations which we had to do. So starting from the entrance, where we had to have a wash basin for the patients to do hand hygiene. So everybody kept touching everything from the soap to everything. So we came up with a plan to make ourselves. You know, at the lockdown, we were not able to get anything, but we managed to do ourselves a foot-operated hand washing stations in most of the entrances wherever we had. And we also removed the tap here so that they don't touch. If they see a tap, they automatically touch it. So we put a shower-like thing so that they don't touch. And everybody were comfortably started using it, and now it's become a routine practice. Same way, you know, the electronic dispensers are available now, but to begin with, it was very difficult to get any dispensers. So this is what usual. So we are all worried about the different touch points which is happening and the virus spread and the amount of virus in different situations for a longer period of time. So we developed this foot control hand sanitizer dispenser. Now this was done right by our maintenance team. So they came up with this idea, and they also made a video on how to make this. And this video went viral across the country. There were more than 200,000 views, and a lot of people made their own dispensers at their own facility. So this roughly would cost us $15 to $20 to make, and it made a big difference during the lockdown. And the best part is it's totally maintenance free. There is no electricity involved, and with a simple foot control, you get the sanitizer being dispensed. And coming to waiting areas like this, many of them have done a lot of things to maintain social distancing. So people have tried to block the chairs, they put some crosses on top of it, they've kept a lot of things there so that people don't use. But whenever we do something like this, people leave their bags or x-rays or CT scans on top of it. So to avoid that, what we did was, we removed the central chair. And that made a big difference. So you don't need to unnecessarily sterilize or decontaminate these chairs, and automatically the social distancing is achieved. So wherever possible, we try to do something which is kind of more systematic so that it kind of easily followed. Same way, this is another example. We don't have automatic doors in our operating rooms. In most of the developing world, it's more like where you have to open with your handle. So we wanted to kind of bring it down to foot so that that handling is not there. So we developed this ideas where the patients, not the patients actually, at least the staff can open for the patients and make them comfortable to enter. So all these incremental changes were done so that the behavior of our team also changed, and also the touch points which would kind of cause this infection could be reduced. So this is one thing, once you put this, still doesn't happen. So the other next point is you have to remove the handle. So once the handle was removed, automatically people started using this. Same time, we work constantly with our patients. We make sure they work the mask properly. So we come up with some innovative ideas to make sure they make posters like this so that they wear the mask properly, because the optometrists are they have a high chance of being very close to the patient. We have to make sure they are wearing a mask properly and also maintaining a social distancing so that they can be safe. So we constantly engage with our patients, and we have done a lot of things to finally make sure that the atmosphere is safe, both for the patients and for the staff. And again, I thank Professor and also Optos for giving me this opportunity to present some of our innovations during this COVID time. Thank you.
Fantastic. Thank you very much, Dr. Venkatesh. Actually, what I propose to do is, because later on, Tosa is going to talk about digital solution. So why not we just start this discussion right away, right after your presentation, so people won't forget the main message. Actually, your solution is, all these evidence-based management system in our vein, and also your small little innovation is very impressive in terms of food control, and also a lot of this ultraviolet freezing box, amazing, a lot of amazing idea. So what, maybe I just invite our panel to discuss and to join the discussion, and then we got a couple of small questions from the audience, and then I'll ask you later on. So can I pass time to comment on this and share a little bit how you practice ophthalmology in your hospital, in your also very high throughput clinic in Thailand?
Poison, you have to unmute.
You have to unmute, Paisan.
Unmute.
I'm sorry.
Yeah.
Thank you very much for this opportunity. Well, I think Arvind did an excellent job of all these innovations and of the system innovations and also the behavior innovations. Well, in Thailand, we don't have that kind of innovations as much as Arvind. Yeah, but we just keep social distancing and we just wear masks and wash our hands frequently. That's what we're trying to do. And I think Arvind give us, many examples that we can follow. I think, many innovation is kind of cheap and it's practical for many countries to follow. I think this is excellent examples for us.
So can I ask Tosi, in Arvind system, how do you translate an idea into action? Because a lot of people got great idea, but then it's very hard to translate into action. Like remove the pedal and this. This is a big change. What's your system that allow this happening?
That what you're raising is a very, very interesting question. And when Venkatesh has kind of mastered that art of bringing people to come and innovate. So I think it kind of goes back to the DNA of the organization. I think when you're faced with a problem, you have one path is to know that things are not right. The other path is to kind of say, okay, this is what I'm up against. How can I work within this or work around it? Or how can I overcome this? So Arvind's DNA for a long time has been the later, because I think challenges everyone has. There was a time when we could not get IOLs, too expensive, $300 a lens. So that was in the complaint box for everyone. While we decided to go ahead and experiment, and with no experience in manufacturing, we kind of established Orolab. And today it has about, 12-15% of the global market for lenses. So I think it's partly the DNA, which I think the leadership has to promote. And as you have seen, a lot of the innovation that Venkatesh shared came out of Pondicherry, where he himself constantly pushes for newer ways of doing it. And I just want to highlight one point that Venkatesh showed. I think one of the most difficult things in bringing about change is behavior change. So if it's goodness, it doesn't happen. So I think you first will have to kind of explore, can I do it in such a way that they have no option but to change behavior? Like for example, he didn't stress on it. Now when you put this foot thing for opening the door, people still use the door handle because that's easier.
Yeah.
You want them to use that, you remove the door handle.
Yeah.
So the behavior changes.
Yeah.
So I think we have to start thinking almost in reflex, not only the innovation, but also its adoption, and not only its adoption, but its spread as well. So I think when you think a bit holistically in that fashion, I think innovation happens. I think once it starts, it kind of infects others, and you only have to create an ecosystem for it.
Very good. But by the way, are you using the same protocol in all your hospital, like the same protocol?
Yes.
Yeah, almost the same. There are differences because of the layout and other differences which within the hospitals. But most of the innovations, again, what you saw, we have been closely sharing between all the hospitals, and like some of the hand washed, foot control, fan wash, and everything has been done across the system now.
Yeah. So every hospital has a task force for quick response, and then there are meetings which happen system-wide twice a week. So wherein it's constantly updated, and the local task force on and does the changes. So system-wide it happens, yeah.
So Robert, you are joining the conference in US now. It should be 6 a.m. for you. So can you have a quick comment on this, and then I will ask some questions from the audience for the audience.
Yeah, thank you, Dr. Venkatesh, for an amazing presentation. It was very impressive and quite brilliant, all of the different ideas that you presented, and certainly ideas that are implementable with not a very high cost. And certainly during this COVID time, you know, in America now we're dealing with more cases, so we have actually tried to be more aggressive with preventative measures. For example, you know, we may not have the least expensive way of doing things, but in all of our individual exam rooms, we start putting in HEPA filters individually to try to turn over the room air as fast as possible with each patient. Certainly, you know, we have all of our similar social distancing protocols and barrier shields. But I am interested in hearing more about the use of protective equipment, because we still sometimes have an asymmetry among the staff where maybe some people are getting more PPE than others. And, you know, when the supply is not as plentiful, then, you know, how come some areas are more protected than others? That I certainly think is a major issue. Luckily in ophthalmology, we haven't had as much of an issue as maybe in like the main hospitals where they have to turn over the equipment more frequently for patient examinations, especially with N95s, who gets to wear them, etc. I still think that is an issue, especially with our increasing cases. But for all of the, you know, hand washing innovations and things like that, I think that that's pretty amazing. We probably are more wasteful in America. You know, we certainly can do all the proper things, but you could definitely do it and not waste as much. And so I'm very impressed with that.
Thank you. Thank you very much for your comment. Actually, we got a very interesting question from the audience. Go back. So Dr. Mansoor Faraki asked, like to ask a question. Very nice presentation with very workable innovations. Have you got any cases of COVID infection in your medical staff during the pandemic?
Not in Pondicherry, but yes, in the system, we had a couple of staff infected in our main hospital, one of our tertiary care centers in Chennai, where COVID as a community spread now, and also in Madurai, a few of our staff have been infected, and they have been kind of isolated, and they've recovered now. Definitely yes, but not many. There are 2 in Chennai and 2 in Madurai.
And also one audience asked how you manage your patient during the operations.
Surgery.
The surgery.
So we are just, our All India Ophthalmic Society has given a very clear guidelines of different procedures and where we need to do testing versus no testing. So for all the emergency procedures, there is no testing at this point of time. And also for elective cataract surgery, there is no testing. So we don't test, we just go with, again, the symptoms, and also we do a meticulous consulting before they enter either into outpatient or as inpatient. So at this point, we are only doing that. And there are some states, like I believe in state of Kerala now, it's even for elective surgery, they are mandating COVID testing. And we don't know what is going to happen in the future in our state or in other states of the country. But at this point of time, elective surgeries are happening after seeing for symptoms.
And do you still allow walk-in patient?
Yes. So we are running regular outpatients even to begin with, you know, but we were only open for emergency. But it's like this period, even if you break a glass, it's an emergency, right? Everything happens online. Somebody wants the glasses, has to come to some facility. All the optical shops are closed. So they come here. I just can't say I can't give you a glasses. So it's like most of them are emergency, but still 20 to 30% are still people who come for some of the basic things like dry eye and ocular surface disorders for glasses and stuff like that.
And do you have any innovations help your staff overcome fear to come to work?
Can you repeat that? Your audio is a little low now. Yeah.
Yes. The question is, has all these innovations helped the staff to overcome fear? Like we're scared, get scared.
Again, fear is a perception. I don't know whether we have really. The one way which I can gauge is because I meet everybody. The second thing you can again find out from the way how many people have taken a leave or no absence without our knowledge. And I don't see any absentia happening at this point of time, at least in Pondicherry. From that, I can say that they have been kind of boldly or comfortably working with whatever facilities we have done for them.
And do you still running this outreach screening program and any new ideas?
We have no idea. It's up to the government because the outreach activities, even though it is done by the non-profit or NGOs, it is controlled by the government of India through the National Program of Control of Blindness, which comes under the state and district. So unless they come up with a clear policy of how to do outreach or maintain social distancing, how many patients to transport in a bus to base hospital, they have to come up with all these guidelines. I don't think it may happen in the near future.
Yes, so the outreach as it happens now, I think is quite some time away. But I think what we are advising both internally and to other hospitals that we mentor is to start pivoting and then empower and set up a community-based referral system. Because all of us in Asia who do outreach work recognize that when patients come to the camp, they already know they have a cataract. They already know that they need to be operated. I don't know how it happens, but that awareness is there. Because when we advise them for surgery, they will come immediately, without wanting to say, oh, I have to get permission or whatever it is. So we are now trying to push the development of a community-based referral system, so that even the people, because in any case, we will provide them free surgery, which we can continue to do. And then on top of it, we also are saving money because the entire case finding cost goes away. So at least for the interim, this is what we are kind of advocating for now, maybe for the next. Otherwise, that cohort of people will remain blind, which I don't think is fair. Yeah.
So you actually change your strategy in terms of patient identification from outreach program to more like vision center and that's more sustainable program.
Yeah. So that's actually an interesting question because with all this lockdown, the major challenge is mobility and access. So the closer there's an eye care facility, the patients are able to go. So once our lockdown lifted, the very severe lockdown lifted in Tamil Nadu, almost immediately the demand bounced back to close to normal in the primary eye cares, in the vision centers. Now they normally see around 25-30 patients a day, and that happened almost immediately. The smaller hospitals, the demand bounced back to about, say, 50, 60, 70% very quickly, within a week. It is these large hospitals where patients come from very far distances because they're tertiary in nature, where, like say, Madurai, after about almost a month of opening, had reached only around 35-40%. Of the volume. I think similar for Pondicherry as well. So the point you're making is appropriate. I think as a long-term strategy, we need to kind of promote primary eye care points, which are more. Yeah.
I think to explain your whole idea will require another MBA course. So for another like a more specific theme, like a lecture. I think we should move on. So then we'd like to invite Tosi to tell us how can we use digital strategy and make us even stronger after the COVID-19. Tosi, please. Just break the.
I thank Dr. Ming and Aptos for this opportunity to share some of our thoughts on how we can emerge stronger from the COVID-19 pandemic and continue to provide eye care even more effectively. We have just heard from Dr. Venkatesh as to how we are managing the now. My presentation is about some of the digital initiatives which are already deployed or being planned for the present and future. This current crisis brought about by COVID is no exception. And it will be a shame to let a crisis of this magnitude go waste without reaping some lasting benefits from it. Hidden in every problem or a challenge is an opportunity waiting to be exploited. Greater the problem, bigger the opportunity. I'll be sharing some of the opportunities that we plan to exploit. Our main goals at this time, when the spread of COVID-19 infection is still accelerating, are first ensuring the safety of our staff, because without them there is no service. Next, ensuring the patient safety and building trust in them that our hospital is safe. Both of these require the use of personal protective gear, physical distancing, and following protocols including decontamination process. While this might give some protection, it will also result in serious reduction in our already stretched capacity. We will end up seeing less than 50% of the normal, even if the patients are more. This will have serious consequences on everything: patient satisfaction, finances, and sustainability. At Aravind, patient intake is largely walk-in without an appointment system. This may be true in several practices. Patient arrivals tend to be bunched. In Aravind, over 85% of the patients arrive by 12:30 p.m., even though we are open till 6 p.m. We have a lot of slack in the afternoon, so we figured that introducing a scheduling system to spread out the demand could more fully use our capacity. Our modeling showed that even with the COVID protocol, uniform patient intake will help us operate at 90% of our pre-COVID volumes. We have already implemented this system, and in the smaller hospitals where the demand has fully rebounded, they're able to see all the patients following the new protocols. At this time of COVID, patients are understanding and appreciate the need for this, so there is no pushback. Many of us have deployed electronic medical records to capture all aspects of the caregiving details. Those who haven't should seriously consider, as this can be leveraged beyond just patient care. I'll be sharing a few ideas that we are working on based on the electronic medical records. A cardinal rule is that bottleneck should never do unnecessary work or be idle. Since the capacity will be our bottleneck, we need to ensure that we are not dealing with unnecessary work. One place to look for this would be to see how many visits it takes to close an episode. say for a pair of glasses, conjunctivitis, cataract surgery, etc. If we can monitor this and take steps to aggressively reduce it to as close to 1 as possible without affecting outcomes, then it becomes a win-win for the patient and the hospital. It would save a lot of money for the patient from reduced visits, and that many slots open up for the hospital to see more patients. A third idea, capacity is essentially chewed up by what all we do in the hospital. We now need to stand back and ask ourselves, can some of what we do in the hospital be done outside of the hospital or by the patients themselves, just as airlines and banks have done? Some of the functions that offer the scope of being done outside the hospital are registration, recording history, insurance-related paperwork, and to some extent health education. Similarly, when the patient is in the hospital through a well-designed app, a lot of activities like navigation within the hospital, information about specific tests that will be performed as a way of preparing the patient, information on waiting times can all be fed automatically to the patient and thereby reducing that much work for the system. We need to innovate and leverage technology to engineer this shift. A fourth thought, capacity is also defined by how long a patient stays within the hospital or the total cycle time. Less time the patient spends in the hospital, more patients that we can see. Taking steps to reduce this will also be another win-win, as no patient wants to spend time at the hospital. With an EMR, we can get such granular data to do a good root cause analysis and arrive at improvement strategies. A fifth thought, today telemedicine technology is rapidly maturing, and so are the laws and rules as well as reimbursement. Patients' willingness to pay will also increase as this service becomes common. Some of us are already into telemedicine of the B2B sort, that is business to business sort. For instance, at Aravind, we do over 2,500 real-time teleconsultations a day for patients coming to our vision centers. This is a B2B model. Now we need to work on a B2C model or business to customer model of interacting directly with the patient. Many of us are doing this in some manner during this COVID era, or at least we've been pushed to doing this. We need to define the workflow and technology for this to work seamlessly. A tele-patient should be dealt with the same level of ease as an in-person patient. They should be part of the same queue, and by clicking on the icon in the electronic medical record, it should launch appropriate communication channel, whether a video call, a phone call, or sending out an SMS. We should be able to shift some of the regular visits to televisits and thus reduce physical load on the hospital. A hospital network that has made great strides in this is the Kaiser Permanente Group, which operates mainly in California. They are the major healthcare provider there. Close to 2/3 of their 150 million patient encounters are digital engagements. They have aggressively reduced the need for the patients to come to the hospital and only if it is absolutely necessary. And that is how they're also becoming profitable. At Aravind, we are working on all these fronts. We are crafting solutions that would work in our context. In some, we have made more progress than in others. We will soon make our electronic medical records telemedicine enabled. We don't think that any of this would compromise quality, outcomes, or the hospital revenues, but on the other hand, can enhance patient experience and reduce cost to them. We also anticipate that when these are made fully operational, our capacity within existing resources could increase by 20 to 30%. So in conclusion, the COVID pandemic is not going to affect the need for eye care, though it could dampen the demand in the short term due to travel restrictions. Whatever hardship this has brought about is universal, and we are not singled out. So it is for us to innovate, stay relevant, and succeed. Thank you.
Once, can you stop screen sharing?
Yeah.
Yeah, very good. Thank you very much, Tosi. Wonderful lecture. I think this is all very high-level hospital management level of thinking. A lot of participants, I think they are maybe like if a clinician, even for a chief of the service, they may not understand this need. But what impressed me a lot is even for the eye hospital, the biggest or the largest private hospital in China, they ask for your help or your consultation to help them improve the patient flow and management system. That really highlights the demand at a hospital management level for a better management, more better thinking on better philosophy and in all this management idea. So, and also in terms of digital solution, what impressed me a lot is in China before in a building office, like people queue up to pay the medical bill, but like when the patient discharged from inpatient service. But now everybody pay on the WeChat. So no more queue at the building office, you just pay online. This is a typical B2C model, right? This is the customer. So the customer can directly pay the bill and then very convenient. I mean, this electronic, simple WeChat solution. Of course, they have to link to the hospital financial system, you know, and EMR system and so on. So I think given the fact that I think Robert is there, Robert is an expert. Robert is expert on digital solution. Maybe I invite Robert to lead this discussion.
Yes, thank you. Certainly there is an opportunity to rethink the way that we do things when it comes to using technology and patient care. Ophthalmology is a little bit difficult compared to a lot of other fields in telemedicine when we think about how much information can you get about the eye from an exam that's done virtually as opposed to in person. So there are some specialties that it is a little bit easier, you know, like if you had to do most of your exam that are related to external things, for example, eye motility movements, external exam. Now we're thinking more like oculoplastics, neuro-ophthalmology. They review a lot of images like neuroimaging, and then they take a look at the exam externally. In those situations, it can definitely be mostly teleconsultations, I would say. And that's the case in our hospital. Our doctors who, you know, need to do inside of the eye exams as most of the key findings, they tend to still, for most cases, have to see the patient. I mean, certainly we can answer questions remotely. We have discussions, whether that's in real time or in the telemedicine style where, you know, they write in and then we write back, so asynchronously. Now that there is compensation for those kinds of interactions, it certainly is more popular than it was before that existed in our reimbursement system. I would just say practically, you know, we have all different kinds of equipment that are trying to be converted to, you know, collecting information remotely. whether it's various different kinds of cameras or sort of maybe like technician-driven acquisition of some data points that could then be looked at, sort of a remote person looking at everything, kind of like reading centers. So we can think about how we do things with reading centers to kind of triage or figure out which patients are the ones who have to be seen in person now that we have to have reduced volumes and more distancing. This could be one way, is that if you had set up a system where some things can be gathered, in open spaces or almost with one person who has all the protective gear, then the other person who doesn't have that gear or don't want to risk exposure, maybe rotate them so it's fair for the person who is as exposed with the protective gear. And then if it's not an emergency, I know a lot of conditions maybe in walking clinics are more like you have to address them right away, but if it's more scheduled, you could come up with systems like, let's say for glaucoma suspects, they don't all have to be screened in person. You could set up a system where you collect your data, like a field or picture, OCT, whatever is the standard, and then you can have someone kind of look at that remotely, just like Arvind already does that with a lot of their outreach centers, and have the mothership do the main screening and deciding who needs to actually come in. I think that is something that should be more common and can become more common in our era. A lot of this has to really focus on safety of the team, I think, in addition to providing the care that we normally do. So I think some of the highlights, I've been watching the chat box for the main protections of both the staff and for the patients. Yes, it'd be nice if we can do more teleconsultations, but a lot of things in ophthalmology, we still have to check, in the anterior chamber or the pressure more accurately with applanation, for example. So I just want to highlight that because we believe that most of the transmission, especially community transmission, is through aerosolization, that we really emphasize on the mask usage. So for example, if someone brings in their N95 but has an exhalation valve, that could be spreading virus. So we put other masks on top of their masks. So we have a lot of the surgical, less expensive masks that we hand out to everyone, staff and visitors, and we have them put that even over their cloth masks that they bring in. It's just mandatory so that everyone feels like, okay, it's standardized to one situation. And we now also put in the HEPA air purifiers, since we had all the increased cases in the US in the individual rooms, because hypothetically, if you're not wearing your mask properly and there's a little air leak, or sometimes we tape the mask so that it's not leaking, like when they do visual fields, et cetera, in these small rooms, you have something to kind of diffuse the amount that is aerosolized, because the HEPA filters in the individual rooms do about 150 square foot. They turn over the air every 15 minutes in the entire room. So even though we have industrial grade HEPA filters in the building, we also want it localized. So anything that's kind of spewing out, we have an opportunity also to minimize that for transmission. But certainly we wipe down everything. We sort of have our techs have a scheme so they know all the parts to wipe that are, we have training to show them exactly this is what you need to do for every single patient. Maybe this is a very expensive way to do things. We have some automated dispensers, so we're lucky, for the, you just hold your hand out and it automatically dispenses at every access point. So inside room, going outside the room, you have to do it every single time. So that, the doctor is wearing goggles because they get really close to the patients when they're checking their eye pressure. A lot of people either bought their own, or sometimes some things have been distributed by the hospital, but it's sort of very asymmetric in the situations. Sometimes it's there or not. So I think although we talk about a lot of the telemedicine and digital future, I think for the most practical from this session, what can we do? Focusing on spacing of the patients, scheduling the ones that really need to be seen, deferring ones that don't need to be seen right away, and figuring out how to do that safely and easily on triaging, and then making sure the mask wear for both the patients and the staff, as well as like they know what symptoms to look for. Like maybe not a lot of the people who answered the phone knew that losing a sense of smell was an important sign that maybe they should be checked out. So we have, special trainings for everyone to keep them updated continuously about what's going on, what are the new findings. We force them to we actually use QR scanner now finally in the US a lot. So we have to scan the QR code, sends us to the website. We do all the symptom checkers every day, daily when we go in, so that people are vetting, that they're there, how are they feeling, and then you can easily contact trace if you need to track someone. We actually stopped doing temperature checks because we did like thousands of temperature checks on everyone who came in, and we didn't catch anyone who was positive, so it was not as useful. But it did give people reassurance when we were doing it. And luckily for our staff and at Stanford Hospital, for doctors, we didn't have anyone who test positive or get a little outbreak, but we did have some people in cubicles who were schedulers who actually, we had a minor, small outbreak, but that was able to be taken care of right away. So for ophthalmology so far, I think all of our measures have been pretty good. We test all the patients before surgery, our COVID testing requirement, or if they didn't get it done, we do it right at the day of surgery, so that at least we can follow them afterwards if it turns out to be positive. I mean, all these things only started more recently because, right at the beginning of our US outbreak, which is more like in February, of course, we didn't have everything, but by April, we started implementing most of these policies because our equipment supplies and everything and knowledge got much better. So yeah, thank you.
I think we have questions from the audience. I just allow him to join in. For a manager, I think it's a she. So can you just ask the question in voice? So maybe I'll invite other panelists to comment on the digital solution to cope with COVID-19. Can I ask Robert, in Nepal, what's the situation and how do you deal with this COVID-19 in your clinic? Robert? Let me unmute.
Yes. Thank you. Very nice presentation. Yeah. In Nepal, recently the cases are very much increasing every day. Average like 5,000 testing, 500 or 600 cases are detected with COVID. And in our part, most of the cases, almost like more than 95% are asymptomatic case, and mortality also not very high so far, like 0.12%, something like that. And in the hospital, in Pilganga Institute of Ophthalmology, we used to see the cases like average 1,000 cases in a day, and now the cases has been drastically reduced. We see average like 300, 250 to 300 is our average, and we have managed, like Dr. Venkatesh and Tulsi sir said, like we have triaging system where we screen the patient who have red eyes and then who are coming from the red zone, that are the cases, the areas where there are lots of COVID cases. So we segregate these cases first, and then physical distancing is we have maintained, and we have maintained all the safety measures for the staffs with PPE and face shield, mask. So these all are compulsory for the staffs who comes in the front line. Then the patient should compulsory use their face mask, and the mask with many people wear the cloth mask also, but we encourage the patient to use the surgical mask, and the surgical masks are compulsory for those who go for surgery and go for laser therapy. So, and then in the surgery, initially during the lockdown period, we used to do only emergency cases like perforation, like case endophthalmitis, but gradually we are shifting now we are shifting towards gradual progression of this cataract cases, and then intravitreal injections, and we have actually started all sorts of surgeries, but you know, with PCR, RT-PCR is very limited in our part, so we have made compulsory for the cases who underwent surgery, for the cases like who have to undergo general anesthesia and the long procedures that takes more than half an hour, like vitrectomy and other long procedure. We do this RT-PCR, and then those with intravitreal injection, short procedures, including cataract, we do it without RT-PCR, but we take very good precaution, thinking that any patient can be a COVID positive. So we are taking all measures, and that is how. And regarding the registration, we have extended the registration time so that we can see the patient with wide spacing, so they don't need to rush in the hospital in the rush hours in the morning. So we have increased the registration time, and emergency care is 24 hours. So we are adapting to this COVID-19 gradually.
Very good. Thank you very much for and sharing all this great.
Yes.
Because we're actually running late a little bit. So so before I close the sections, I would like to bring people pay attention to the webinar chat, where one of the audience shared actually in the AO website, there's a guideline and clinical video where we can see how to manage cataract surgery during the COVID-19, and there's also an AO guideline for COVID-19, the ophthalmology practice guideline during the COVID-19 as well. And then some audience asked for what's the size of the slit lamp shield, and a lot of other details. And then some audience asked for to access the video of the webinar. So I just try to briefly explain that. Actually, APTOS, there's a website. So if you just, I think, pay a very symbolic fee, very $20 or whatever, I forgot, a small symbolic fee, then you become an APTOS member, and then you'll be able to access not just this webinar, but also many other, I mean, the APTOS annual meeting video and so on. So it's a good opportunity for people to learn what's happening in our previous annual meeting, and also the webinars that we're going to run for APTOS. And then I'm going to announce a small news is that in next month in August, we're going to run this webinar with APOIS, Asia Pacific Ocular Imaging Society. So you're welcome to join, and then we will send this the news and invitation very soon. So lastly, I would like to thank Dr. Venkatesh and also Tusi for sharing all these great experience, ideas, and thinking in Aravind. We have been learning a lot. Again, this video has been captured so people can watch it later on. Thank you very much. Thank you, and also thank the panel and the audience to participate. Thank you very much.
Thank you.
Have a good
Thank you.
day.
Thank you. Bye.
Thank you. Thank you.